I'm Dr. Anbumozhi, Professor of Pathology from Sree Balaji Medical College and Hospital. I'm into the teaching field for past 15 years for both UG and postgraduates, which being my major passion. I'm also a quality manager of both NABL and NABH handling hospital side. I'm also a member of medical education unit for past 10 years, which is a major passion for the teaching. So topic of the day is general pathology, where neoplasia is a big and a major topic from general pathology. So neoplasia being a major topic, today we are going to see only about the introduction of the neoplasia, which handles the 5 major objectives in the topic. So the major 5 object and the take-home message for today will be about the introduction to neoplasia, the components of the neoplasia, then moving on to the classification or how they have defined detailedly about that, then moving on to the spread. So these are the 5 major components or the objectives for the topic for introduction of neoplasia is what we are going to discuss today in today's class. Starting on to the topic, as I've told, first the introduction of the topic. So the topic for today, neoplasia. Introduction, split up the word, neoplasia. Neo means new, plasia is growth. So from the word itself, you get the definition. So please don't memorize about the definition. It's about neoplasia, a new growth. A production to the new growth is called neoplasm. So this itself talks about what is the definition of neoplasia, a new growth which happens in the body. So moving on to the detailed classification before that, you should also know about the normal cells, which you will already been learnt about. A normal cell where it needs a growth factor, the growth receptors, which will lead to a cell for its division, and it will be a programmed division where it will be under a controlled. It will have its own receptors for the control and its proliferation. In this normal is being disturbed. So that leads to the uncontrolled proliferation. Even after the stimuli is being removed, this proliferation goes uncontrolled, unimaginably big. So these are the terms we put into the definition of this neoplasia leading to the growth, which is called as neoplasia. So the definition is it's an abnormal mass of tissue, the growth, which is being totally uncontrolled from the normal tissue where it persists even after cessation of the stimuli. So these are the cardinal features where you have to put it into the definitions. Please don't memorize and put it. It is abnormal growth, uncontrolled, which persists even after cessation of the stimuli. So the first thing is the definition with the introduction is over. Then moving on to the components. The components, what I actually mean is, if you take a tumor, what is that actually you have to see from the pathology point of view in a microscopy. So basically when you take a component in a microscopy, you have to see what is a parenchyma, you have to know, and you have to know what is a stroma. You should also be knowing about what is desmoplasia. These are the few new terminologies in this chapter. Parenchyma is nothing but the actual core content of the stromal cells or the clonal cells. The background to the parenchyma is called as the stroma. And the desmoplasia is what is the long term, the proliferation of cells. There might be fibrosis or collagen deposits in the background, which is called as desmoplasia. These are the few terminologies and knowledge you have to know detailedly about the neoplasia or the understand details about the neoplasia chapter in detail. So we'll see all this further as it comes. So the 3 components you have to know is parenchyma, which is the clonal cells, the background, that is the stroma, and finally the desmoplasia, which happens during the long-term proliferation of the neoplastic cells. So these are few examples or the pictures I've been projecting for you to understand more. See, that is the component of clonal cells, which is the parenchyma, the background, the stroma, and and these pink areas when the long-term proliferation of the tumor cells is the desmoplastic cells. So with these components, we are going into the classifications. The classification, they have neoplasia is benign and malignant. It's very simple. It's benign and malignant. So how will you know any cells which proliferates as benign or malignant? How are we going to call it is our next task. All benign tumors are called with a suffix, the ending as oma. So that is our first point you have to remember. Benign tumors are called, which will end with a term called oma. So I'll give you a few examples. For example, fibroma, chondroma, adenoma, papilloma, cystadinoma. So all this oma, so you can keep it in your mind. These are benign tumors. But there are exceptions. There are only 5 exceptions, which is very easy to remember. 5. Melanoma, seminoma, hepatoma, mesothelioma and lymphoma. So any tumors which end with oma is a benign tumor. But exceptions are only 5, which is easy to remember, are these 5. And moving on to the malignant. How are we telling these as malignant? Why are they called as carcinoma or sarcoma? Is because of its origin. So if any tumors which arises from the epithelial cell of origin, that is basically squamous cells or columnar cells, is called carcinoma. Mesenchymal cells, where the bones or the muscles develop, is called sarcoma. So this is the next thing. So when we are classifying, you have to know 2 things, benign and malignant. When it comes to benign, everything is called or it ends with oma. When it comes to malignant, it is called as carcinoma or sarcoma according to the origin of the cells. So with this, few more examples for your extra knowledge. So I'm just reading it out. See, benign tumors are called as squamous cell carcinoma, adenoma, papilloma, and few more things. And when it comes to malignant, it is called as squamous cell carcinoma, papilloma. These prefix names, it's designated how, now according to the cell, it's of origin, the pattern of arrangement. The papilloma means it will be papillary-like projections. Adenoma means glandular-like projections. So that is how. It's very easy to remember, and as a take-home message, the word itself will tell you how to remember well. Some more examples of the same thing from its origin, just for you to, please don't memorize. You can remember 5 to 6 words accordingly for you to know these are all benign, these are all malignant, and 5 tumors which cannot be benign, even it ends with oma, is what you should be knowing. Okay. Then 3 more things which I want to tell you is about teratoma, chorosteatoma and hematoma. Why these 3 are important is, these 3, the names will not speak for itself. It speaks from its origin, as I've already told you. Teratoma means basically germ cells, ectoderm, endoderm, mesoderm, where all the organs develop. But these tumors develop from the totipotent cells. That is why this is called as teratoma. And the second thing is chorosteatoma and hematoma. The basic 2 differences, hematoma na normal site da, but the abnormal tissue will be present. That is disorganized growth. And chorosteatoma is normal tissue, but in the abnormal side. For example, pancreatic tissues will be found in the stomach. So, annamadri, when it is not the origin of site, where it grows in the different origin, this is the name we usually give. So, these are the next 3 terminologies you should know, apart from knowing benign, malignant, and the other 5 omas of the benign, and these 3 terminologies. So, moving detailedly about differentiation. This differentiation of benign and malignant is the detailed question for you in your university exam, and it is a major basement for your neoplasia chapter to be known. So we have categorizing this again into 5 main headings. Rate. Rate means the organized growth of the tumor is what we mean. Clinical features, gross, microscopy and spread. Everything has a very clinching point. If it is asked for 5 marks, you can write it accordingly 1 or 2 points. When it asks for 20 marks, you have to write in a detailed version. So first we'll talk about rate. Rate means, again you split it into rate of benign and malignant. When you take any tumor which is being benign, it is definitely, it's a small tumor. It will take its own time, which will be slow growing for a long time. But when you take a malignant tumor, the rate of growth will be faster. The shorter duration, it keeps proliferating more and more and more, which we already know what is that neoplasia. The proliferation is more, that's what it means. So that is what we talk about, the rate where benign and malignant. So that is the first point. Second is clinical features. When they're coming to your OPD, any history you take will give you a clinching point about whether it's a benign or malignant. The duration is for a smaller time, and the clinical feature is there's a small lump where it is not painful, where it is not even tender. These features will tell you that it might be benign. And when you take a malignant tumor, it will be aggressive growth where it will be a big mass. You can even find some lesions over the mass where it will be tender, it will be very fixed, hard, and these features. So As the name implies, benign, small. It'll have its own features. Malignant, so it'll have its own bizarre features in the gross appearance clinical features as well. So the third point is gross. I've put a picture of gross where there is one lesion. If you see, it is well circumscribed. It has a nice capsule. You can define the shape of it. These are all benign tumors usually when you receive from the histopathology or as a gross feature when you see it in your pathology. By you looking at itself, you can tell it is benign. But when you see a malignant tumor, see how big it is totally disorganized. You cannot tell the shape of it. And you can see lot of necrosis surrounding it, and there is no capsule in it. So these are the gross features of benign and microscopy. I'm coming again, the 5 major points of differentiation. We started with rate, where it is slow and fast growing. The second thing, clinical features, where usually they don't give a small history about benign. When it comes to malignant, where how bizarre and painful and tumor is huge. When we receive a specimen, how well encapsulated, it has a shape. It usually compresses the surrounding part, but it will never penetrate. But when you take a malignant thing, it will compress, not even compress, it will penetrate, and it will have a bizarre features, and it will be totally it will not be capsulated, and it doesn't have a proper defined outline for it. So with this 3 major feature, the fourth one we are moving on to is microscopy, the major thing, and only the microscopic feature of this neoplasic differentiation can be asked as a short note, so which is very important to memorize or to take it home message easily. Just remember 10 points in it. The 10 points are put under a single word called anaplasia. So if you define this word anaplasia, split it up into 10 features. These are the major 10 points for your microscopic feature. Moving detailedly into it, the first feature is, I've put 2 pictures. One normal cell, how will it look? See, it has a well-defined margins, how it will have a nucleus, a well-defined cytoplasm, how all the cells are arranged in a orderly manner. And another picture where it is so disorganized and haphazardly that has been drawn. So every single feature is a point of an anaplasia. So the 10 points moving off to anaplasias, the first is basal polarity. What do you mean by this basal polarity is, it will have a basement membrane. The nucleus will be nicely sitting over it with the surrounded by the cytoplasm is the concept. This is maintained and benign, but whereas in the malignant, it is totally lost. It will be haphazardly present. Can you see the picture? It will be haphazardly present. We don't know, we cannot define it. So there will be loss of polarity. Second thing is pleomorphism. Pleomorphism is, it will not have a definitive shape or size, which you have already seen in the cross also. I have told you the same thing. The same way, the nucleus and the cytoplasm will not have a defined thing. It will be totally disorganized. Second thing, always the nucleocytoplasm has a ratio. Okay, the ratio will be totally disturbed. Usually the nucleus will be 1, for example, the ratio is 1:2, but here the ratio will be, we cannot predict it. It might be 2:2, 2:3, 1:1. It will be, every cell will have its different own ratio. The same way, can you appreciate all this? So if you see, one cytoplasm is more, another cell the cytoplasm is less, one cell is big, one cell is small. This is how haphazardly it will be arranged. Next is anisonucleosis. They are talking only about the nucleus. Till now we are talking about a cell, how it will be arranged, how the shape will be there, nucleocytoplasmic ratio. Now moving in detail only about the nucleus, they have 3 features next. Anisonucleosis, nuclear hyperchromasia, nucleoli, which means only about the nucleus. They are telling about 3 features. Anisonucleosis, as usual, it will have different shapes and sizes, what they again mean. Nuclear hyperchromasia is, inside the nucleus there will be still more proliferation is more really. Actually there will be totally disorganized proliferation, and all the organelles will be totally disorganized. That is the feature which tells about this nucleoli, which is more darker in feature. Next is nucleoli. These features which is being more prominent is what they mean. So these 3 features about the nucleus. Next, abnormal proliferation. So definitely the mitotic figures will be more. And finally, these cells coagulate to form a bigger cells is called giant cells. Next, There will be again, because of this cytoplasm which thins and liquefies, which leads into a mucin like secretions, is called increased mucin content. And finally the aneuploidy differentiation of benign and malignant, where benign is usually diploidy and malignant is aneuploidy. So these are the 10 major features of microscopic feature which differentiates between benign and malignant. The single word which differentiates benign and malignant is anaplasia. To define this anaplasia, there are 10 points. These 10 points starts with the benign is they maintain the polarity and malignant is loss of polarity. No pleomorphism in benign, there is pleomorphism in the malignant. The NC ratio is altered or in the malignant, where it is maintained in the benign. There is anisonucleosis, hyperchromasia of the nucleolus and nucleoli with increased mitotic figures in the malignant, followed by tumor giant cells and increased mucin secretion with DNA aneuploidy. So these are the 10 major features for the anaplasia. So the fourth major point is also over. So the final thing is spread. What the spread is? The tumor grows in a place with lot of factors initiating it or any DNA upload. Okay. Will that be only confined to that place? Will it move on to the other place? Yes, definitely. The benign tumors are confined to only one region. But whereas when it comes to malignant, it has the capacity to spread from one area to the other. So that is called invasion or spread or metastasis. So the last major point for the topic. So how does it spread? It spreads to another point through three major routes. One is transcoelomic spread, that is through cavities. Then is the lymphatic spread. Next is the hematogenous spread. This transcoelomic spread and lymphatic spread are less common when compared to the hematogenous spread. Hematogenous spread is also another important thing. Why is there are two vessels. There are arteries as well as veins. Through which it spreads is the first logic. Arteries are thick-walled vessels, but whereas veins, they are thin-walled vessels, easy to penetrate. So majority of the tumors spread via veins. So this logic is enough for now, because which tumor spreads by vein and artery through where, it again becomes a detailed topic for the next session. So we'll just know the spread is there. It is through three types: transcoelomic, lymphatic and hematogenous. For this spread, it is called as metastasis. So as I've already told, the development of secondary growth of malignant cell at a distance from the primary site. So a tumor from the primary site discharges and goes and proliferates in the secondary site is called as metastasis. So again, I'm telling, please don't memorize the definition, understand the concept for your better implementation. So as well as these metastasis has 8 cardinal features. So always remember this. This 8 features how the tumor proliferates and leaves the normal site, enters into the hematogenous or the blood or lymphatics or the transcoelomic thing, moves on and goes and settles down into the secondary phase, and again there it proliferates, it's metastasis. So how this happens, you have to know. The take-home message is 8 points. First, there's a tumor, primary site. Definitely it is an aggressive growth. But there are few cells in between which will be more aggressive, where it wants to proliferate more and more. These forms a small clones. They dislodge from that primary site. With the help of the E-cadherin, they loosens and they enter the extracellular matrix. I've given a picture of it where it's a well-defined picture where you can follow the picture as I tell you. See the topmost picture, the primary tumor. Okay, there are few cells. Okay, there is a differentiation of color. Okay, these cells proliferate, form a small clone. They, with the help of remember this word E-cadherin, loosening of the cells happen where they cross the basement membrane, entering into the extracellular matrix. The in between that pink area, that is the extracellular matrix. Okay, just keep it in mind. So there they lodge over there. So what the first will be? So the first point is aggressive clonal formation, I've told you. Next, loosening of the cell. And interaction with the extracellular matrix. 3 points. Well, how does it happen? With the help of the E-cadherin. Clear? Next. Now, in this extracellular matrix, they have to again degrade this and enter into the blood vessel. So, that will be the 4th point. Degradation of extracellular matrix. Again, to degrade this extracellular matrix, we again need few factors. What are they? Collagenase, elastinase, metalloproteinase. So, the first word you have to remember is E-cadherin for the loosening and penetration into the extracellular matrix. Now, for degradation of extracellular matrix, we need another 3 points, that is collagenase, elastinase and metalloproteinase. After degrading, the 5th point, they enter into the blood vessels. See, any antigen, for example, entering the blood vessel, what is the concept? The WBC should come, it should engulf, it should go, it should fight, it should take it away from the area. That is the concept of antigen. The same way, this clonal cells, after entering the blood vessels, the same thing will come, but these are proliferating. These are clonal cells of different origin. Yeah? So these cannot be removed like a normal antigen, but it will be covered with all this WBCs and other things, forming into a separate mass, which is called as entry of tumor cells into the blood vessels. This mass will travel from here. This mass is called thrombus formation. This moves in the blood vessels from one area to the other area. The same way, from the blood vessel to the any secondary portion, there will be extravasation happening, where there will be dislodgement from the blood vessels and reaching the second point wherever, which we'll deal later, and settled over there, and where the secondary mass proliferation happens. So this is the 8 points of the metastasis simplified version. So again I am telling, first is clonal expansion or clonal formation, that is tumor heterogeneity. Next is tumor cell loosening with interaction of extracellular matrix by E-cadherin. The 4th point is degradation of extracellular matrix with help of collagenase, elastinase and metalloproteins. Entry of tumor cells into the blood vessels. Thrombus formation, extravasation and secondary mass deposits or the metastasis with the help of the other growth factors for them to lodge. So, with this, the 5 major points of differentiation of benign and malignant is what is covered. So, just a small recap. Today's topic, neoplasia, which is classified under 5 heading of introduction, then what is the definition, components, classification of neoplasia. In that, the classification and the differentiation, 5 major points is what is the rate of proliferation of both benign and malignant, clinical features of benign and malignant, gross of benign and malignant, microscopy of benign and malignant, where single term to be remembered is anaplasia. Then is the spread through 3 types, that is lymphatic, hematogenous and transcelomic. For this spread, this is called as metastasis, which 8 cardinal features to be remembered for the secondary deposits. So with this, I am winding up for today's session with the references. Shall meet you with another interesting session soon.